So we've presented this week at EuroPCR the physiology-stratified analysis of the ORBITA trial, looking at the endpoints of ORBITA and trying to see whether we could tease out exactly which patients benefited the most from angioplasty based on their baseline FFR and IFR metrics. And what we've seen from this analysis is a very strong correlation between baseline physiology, the FFR and the IFR, and the placebo-controlled improvement in stress echo score. So the lower your FFR or IFR value, the more likely it was that angioplasty would produce a greater benefit on ischemia reduction on stress echo. And that relationship was very, very strongly correlated for both FFR and IFR. And that's very interesting because we can now see that the reduction in blood supply to the heart at the outset very much correlates with the improvement that we see on stress echo when we fix that with a stent. So what we were able to do in this analysis is now we're able to look at further secondary endpoints that we perhaps hadn't pre-specified in the initial analysis. And for that, this time we looked at freedom from angina on the Seattle Angina Questionnaire. And what we found was that in fact angioplasty improved your likelihood of being free from angina much more so than placebo. In fact, for every 100 patients you treat, 20 more patients will report that they have no further anginal symptoms in the angioplasty arm. And that's a new bit of data that we didn't have from the initial data set. Well, I think it's good for doctors. We can now have, for the first time, placebo-controlled evidence of what we do. So we can say to patients, I can measure exactly how significant your lesion is by using IFR and FFR, and on the basis of what I've measured there, I know how much improvement I will have in the blood supply to your heart when I stent that patient. And obviously the tighter that narrowing, the more improvement you may stand to gain, and that's great data. It also means that you can tell your patients that you have a higher likelihood of being free from angina in the first placebo-controlled trial. That likelihood is not 100%, but there is a 20 absolute point difference between the two groups. That was a very interesting study, and I was very honoured that the investigators chose to use the ORBITA placebo or sham arm as a control group for their study. I have to say that science isn't that easy, and if it was that easy we wouldn't need randomised control trials. It's very difficult to take an unblinded arm from one trial and take a blinded arm from the other trial and form any comparison that is, as they did, a statistical analysis giving us p-values. Those two groups are not comparable. It's perhaps not within the normal remits of what we do in terms of academia, because of course the point of a randomised control trial is that those groups are well matched, and therefore they are very similar and you are able to just randomise them based on their intervention. So interesting data, but not data that adds very much more, and I'm not sure quite what to make of their results. Believe it or not, this physiological stratification of the endpoints was actually one of the major aims of ORBITA. We expected that angioplasty would improve exercise time with a large effect size and symptoms, and that we could then tease out how physiology affected that. What we're going to be doing next actually is looking at stress echo. So looking at the baseline stress echo and seeing whether how ischemic those patients were on baseline stress echo has any correlation with the placebo-controlled impact of angioplasty on all of the endpoints of ORBITA again. And we hope to be presenting and publishing that towards the end of the year, and I'm working on that at the moment. And we're planning for the next trial, ORBITA 2. At the moment that's in the kind of design phase, and we're looking for funding and trying to get that together. Looking at how we can expand what we've done with ORBITA 1 to a wider patient population of stable angina patients, so that we have more answers for patients outside of that single vessel coronary artery disease group. ORBITA's been extremely controversial. It's been a trial that everyone's talked about a lot. But actually the highlight, or the real headline from the first manuscript, and really this manuscript, is that we were trying to look at how placebo influences what we do. And really it has highlighted that placebo control is necessary in trials looking at subjective endpoints, and perhaps we should think about placebo control trials a lot earlier. But the other thing I would say is what we're starting to understand now is that the relationship between angina, seeing a tight stenosis on an angiogram, relief of ischemia, and then symptoms and exercise time is not the simple relationship that we expected. It's much more complex. There is an interplay of many other factors, And hopefully, perhaps with this next paper from ORBITA, this paper from ORBITA and the next, we can understand ischemia better.